Thank you very much. The only bad news is that in Italy now is dinner time. So I'm kind of sad to upset my colleagues and my friends in here who has to, have dinner in front of a screen while we're talking about fistula, but it is what it is. So thank you again for having me. It's great to talk about this great topic between friends, I would say. So I will try to keep this part a little bit informal so you don't get bored. So since the very first slide, I think you can realize how much I care about Her Majesty, post-operative pancreatic fistula. I'm going to focus more about how to predict and mitigate such a thing, while then it will be a matter of Keith to teach us how to be better surgeons. So I will do the easy part. So Her Majesty fistula. I mean, I love the title that you chose for me, because to predict and mitigate something, basically it means that we cannot avoid having a fistula. So basically the fact that we are facing that fistula is there and unfortunately is here to stay. So we're going to try to predict and mitigate such a thing. And we're going to start from some high level evidence, okay, that I took from a very famous TV series since the last decade. So let's learn from these high level evidence.
Eli, I need another sample of Mr. Rabb's fluid.
Oh, that's going to be tough. I took the drain out.
You what?
No, with the drain in, he can't turn over, which means he has to sleep on his back, which means he isn't sleeping. So.
Okay, just call radiology. We have to put it back in. They need to be able to see the fluid to tell if there's an infection.
Well, I can tell by looking at it that it's not infected.
Just call radiology.
Look, if Dr. Bailey wants to put back in, then I will.
No, she's in surgery.
Well, then it'll have to wait.
Well, he's right. His patient records for the past 3 months show a post-op complication rate way lower than the norm.
Wait, 12% compared to 42%?
Yeah.
Wow.
Okay, can you two stop being impressed by him? It's a fluke. He's mean.
Hand me those charts. I think he's kind of hot. Can you say that about a nurse?
No.
Day 3. Day 3.
A bracelet with his name on it.
Hey, if we remove the drain on day 3 instead of day 5, we can reduce the formation of fistulas by 30%. Miranda Bailey is going to cure fistula.
Okay, so looks like we're dealing here with such a hot topic, okay? Because even Grey's Anatomy tackled this in one of, of his stories. But I mean, this is just to, keep in mind how huge is this issue we're going to tackle. So going back to our webinar, I think that we cannot avoid talking about how to define such a complication, because to define something, I think this is a great example on how we need to talk the same language in order then to tackle this issue altogether, because it sounds crazy how back in the day, before 2005, several, I would say dozens of different definitions of fistula existed. So it was by definition impossible even to compare outcomes between centers and surgeons. So can you realize how impossible it was at that time to try to find a solution for such an issue? So this was, of course, done by the ISGPF at that time with a definition of fistula, which is now in the books. I'm not going to stop here. I just want to highlight how this definition also provided some grades, which were the A, the B, and the C. It became, over the year, I would say, a trademark of the ISGPS. But this is important because it's important to show once a definition and a complication might either be clinically relevant or non-relevant. This is very important for surgeons. And of course, this definition was not perfect. It was known since the very beginning, but without a definition, it was impossible to start to assess things the same way. Which were the criticism at that time? Well, the first one was that the concept of non-clinically relevant made the grade A more similar to the non-fistula world than to the fistula world. And then also the clinically relevant thing was actually kind of tricky, because at that time, we were not so, let's say, familiar with percutaneous drainage angiography, endoscopic procedures. So the border between B and C was actually not so clear at that time. So that's the reason why 11 years after, fistula was redefined again by the ISGPS, that now whenever we deal with the fistula, by definition, we are defining a clinically relevant entity. So we have now a biochemical entity, which was the former grade A, and also I would say a more defined border between B and C with all these minimally invasive, we can say, so endoscopic percutaneous procedure pertaining to the B world. While we mean with a C-grade fistula only once reoperation, organ failure, or death occur. So now that things are clearly, and of course we had a drop in the overall rate of fistula according to the new definition, and we have now a broader, I would say, entity, which is the grade B, while grade C is actually less frequent, but I would say more relevant also in terms of cost, because these patients are mostly managed in the ICU. I think we're now ready to start talking about how to prevent and how to mitigate such an entity. So we're basically dealing here with the preoperatively and the intraoperatively setting, while it will be, I would say, Keith's task to then show us what to do after surgery. So I'm going to start, well, first of all, telling you that the good news is that no more classification so far in grading, but the bad news is that still we are dealing with a major outcome determinant, because we all face fistula, not only in Gray's Anatomy, but in our everyday practice. And starting from the preoperative setting, we are now able to define a risk based on such parameters that we defined in this recent publication, which is very important in some, I would say, specific scenario. You can see here that in this model, which is, I would say, pretty easy, we are also able to define that in this fork, the duct size and BMI already define a risk of fistula even before the operating room. And why this is important? Well, this is important because whenever we face entities like cystic neoplasm of the pancreas or neuroendocrine tumor, basically those entities in which we have to scale the pros and the cons of doing a Whipple, then the risk assessment, starting even from the preoperative setting, might be a factor in the equation that we want to keep into account. And of course, by improving the patient selection and the counseling, we can also already define our decision making. We can, of course, define whether to apply or not ERAS protocols or other studies that we have. It's starting since the very beginning to be a crucial aspect to define whether a patient is more likely to develop a fistula. And this concept will remain until the entire time in the operating room and day after day until the fistula eventually take place. So this is a very important concept I would like to stress. And this is nice that, as in a relay between the preoperative and the intraoperative setting, the definition preoperatively, you see here, it's the same that we find then in the intraoperative setting. I'm going to talk now in a minute about the fistulary score. You see that all the preoperative assessment as a low risk are, you see here, found in either the negligible or the low risk zone, while the patients who are already at higher risk in the preoperative setting are now in the intraoperative setting in the area at higher risk of developing a fistula. So we're getting now closer to the eventual fistula formation, and even our ability in defining the risk become, you will see, better. But let's go back a little bit into the definition world. Why I was so concerned about the definition? Because one, when we all, I would say, keep in mind to consider the use of some device, some tools in order to reduce the occurrence of fistula, this Cochrane review actually focused on somatostatin analogs, which were used in Verona till some years ago. And in this review, the overall rate of fistula was actually decreased by the use of somatostatin analogs. However, when we go to the actual data, you see that the actual decrease of fistula was found with the use of octreotide only in the biochemical ones. So if we go to the actual data regarding the risk assessment, the use of prophylactic octreotide is not useful. Actually, in those patients at higher risk for developing a fistula, the use of prophylactic octreotide is actually detrimental. So once again, to define a complication and to grade a complication is of massive importance to define our management. So now we finally move in the operating room. And this fistula risk score has now been incorporated in the surgical practice of many centers all around the world. You see here that we have some factors, namely how the gland looks like, either firm or soft, the pathology while we're operating on a patient, again, duct size, and the intraoperative blood loss. We can discuss about the reliability, but still this is a surrogate of how tough the surgery is. So based on these risk factors, you can define whether your patient is at a higher or lower risk to eventually develop a fistula. And we see now why this is so important. So we start from the negligible risk group. Those are the haired pancreas with a big duct. Those anastomoses are the one we love to do. It's great, you know, to have residents starting to do this anastomosis. In this case, once you assess that the risk is almost zero, you can even consider to avoid placing drains, which is something that was, I would say, kind of crazy 10 years ago. But we found that once we apply this drainless policy in the negligible fistula risk zone, you see that the risk of fistula is actually zero. So the use of drain could be even detrimental in these patients because it's mainly a way for bacteria to come into your fluid collection rather than protecting from a fistula. So again, this is very important because at that time there was a big debate, particularly triggered by the trial by Van Buren, published in Annals of Surgery, in which drainless policies were associated with high rates of mortality. And the reason is because at that time there was no risk assessment. So in this setting, of course, it sounds now absolutely not reliable to avoid putting any drain no matter what, meaning in a pancreas without risk assessment. So as a landmark, we now can apply a selective drain placement policy depending on the fistula risk zone assessed once in the operating room. So we now move into this, I would say, wider group of either low or intermediate risk of fistula. And in this case, what we follow is a policy named early drain removal, meaning that once we put drain, we can, by testing the amylase, decide when to remove the drains, but that's another story. And this is going to be, I would say, the topic of the next presentation by Professor Roberts. So I'm not going to go through that. But I want to spend a couple of words regarding the high risk zone, because in this case is where the mitigation strategy became protagonist. We ran a trial, a randomized control trial, a phase 3 randomized control trial published in JAMA Surgery 3 years ago on the optimal management of this horrible pancreas. So those are only the soft pancreas with a small duct. And in this case, we wanted to challenge which was the best anastomosis in between the PJ and the pancreogastrostomy, which was, I think, very, I would say, fancy at that time, at least in Verona. All cases, you see, were mitigated because it was already clear from retrospective data that in this case, it was better to put an external stent in order to mitigate the formation of a fistula. As expected, we didn't find in the trial a significant difference in terms of fistula rate, but the burden, the fistula clinical burden was actually lower with the PJ anastomosis. So at that time, we defined that this was, in our experience, the best way to mitigate the potential formation of a fistula when dealing with a horrible pancreas. A word of caution should be used regarding stents, because either they are internal or external. We prefer the external one because we can see the actual fluid draining out. You see that there is an advantage in putting a stent whenever the fistula risk score is between 7 and 10. But as I said, the stent needs to work properly, because once we face either an occlusion or a displacement of such a tool, you see that the outcome were as bad as when we didn't put any stent, or even worse. And I'm going to show you why in a couple of slides. So be careful about the technique you are using to secure your stent, because you really want this tool to be in place and working. Otherwise, we can be in trouble. So again, another landmark was that when we're dealing with the high-risk cases, a PJ with an external stent was our choice once in the operating room to either prevent or mitigate a fistula formation. But we want to do better. So as I showed you before, one of our major issues was the potential dislocation of the stent. We are now using pancreas-specific tools, which are actually way better than those that we used back in the day. But we are even trying now with this pilot series coronary artery stent in order to secure our anastomosis. This is, I would say, a very fascinating way to try to tackle this issue. I'm going to show you how. So basically, I'm sorry about the low quality of the video, but this is truly experimental. We put the stent, which of course, by expanding in the main pancreatic duct, is able to be really shaped the way we need it. And once the stent is in, we then perform the anastomosis. So once again, this is totally experimental, but I wanted to show you this because it's a way we are now testing to define would say, an optimal way to drain our anastomosis and to have a stent which is really suitable for the specific pancreas you are dealing with. So I don't have definite data, this is just a pilot series, but the preliminary data shows us that the dislocation could be extremely low. So we'll see maybe in the next future what data will come. So this is, I would say, the final slide in terms of conceptual framework for a risk-based drain management. So everything starts, we see it before the operating room. So we are now able to define the risk of a patient even before going to the operating room. But then the more we move closer to the fistula, which can take place by definition since POD3, we are, as I said before, more able to define the risk of the specific case we're dealing with. So once in the operating room, we always assess the fistula risk score. And then at this point, we decide whether to put or not drains, because as I showed you, when the risk is negligible, drain can be even detrimental. And if we put drain, we start testing the amylase level. And the amylase level are the main driver of these policies, which are, as I said before, the early drain removal policy, depending on the value. But please, again, be ready to change your practice. Because, for example, if you decide to put a stent, the same amylase threshold lose their way to be reliable tools. So we always have to update our risk estimate depending on the specific case. And I want to bring your attention here now on POD1, because it looks like we have now a new kid on the block in terms of complication after surgery, because you know that the ISGPS has now defined the occurrence of pancreatitis taking place after a pancreatectomy. The name is PPAP, post-pancreatectomy acute pancreatitis. Why is that important? Because once pancreatitis takes place, this could serve as an early trigger of fistula. So you can realize that we are now in the very early postoperative setting. So if we are able to define the patients who are at higher risk of developing acute pancreatitis, our capability to define the risk of fistula in this very early period could be even better. So you see how this capability updates itself in terms of predicting a fistula. And I could, predict that the post-operative acute pancreatitis is here to stay, because it will help us in refining our way to define the definition of a fistula. This is my last slide, and this is the concept I want to leave you with. So if you now all agree with me that fistula will always be, unfortunately, a protagonist of our clinical practice, I think that in this journey throughout the decade, we're now getting better and better in predicting fistula occurrence, but there will always be, as in a bottleneck, a rate of patient, a rate of pancreas that will eventually leak. So I think, and I'm curious to get to know your opinion in this regard, that we have now to shift between a prevention in the fistula to a mitigation of a fistula, because you know that in some case, leak will take place. So what do I mean with mitigation? Well, I mean that now in the toolbox of a pancreatic surgeon, to avoid using the octreotide, to keep in mind that you can place phalangogestomy if you realize that the patient is at higher risk, to use the anastomosis you trust the most, which in Verona is the PJ with an external stent, to test your amylase, to manage your drain accordingly, and to study, as I just said, the occurrence of PPAP will serve as the best way to mitigate this leak, and at the end of the day, to be better surgeons for our patients. So I think it's now time for me to pass the microphone to Keith, and I hope this served as a good introduction to the paranoia study that we all know about. Thank you very much, and I look forward for a great debate together.
Thank you so much, Giovanni. So yeah, we'll pass the mic to Keith now, Professor Keith Roberts, who's going to tell us about his pancreatic anastomosis audit, the paranoia study. Over to you, Keith.
Thanks, Adam, and thanks, Giovanni. And I'm sorry we're keeping you away from your lovely dinner. Our dinners in the UK are not so exciting, but anyway, let's get through this, and then we can all go and feed our pancreas. So, yeah, I mean, I think a talk on post-operative mitigation strategies would be fairly short. So I'm a little bit naughty, and I've kind of rejigged the topic, because I think fundamentally, I think there's an opportunity to look at pancreas fistula in a different way, and I'll present some data as to why I think, you know, we do need a slight rejig of how we consider pancreas fistula, and also up until very, very recently, there hasn't really been a step change in how we mitigate pancreas fistula. But the Dutch Porsche trial shows, you know, really very good data on how we can reduce, you know, really bad outcomes in pancreas fistula simply by, you know, looking at CRP and having a very low threshold for CT scan and for intervening. But that's for the Dutch to tell the story, and that is very much hot off the press, and it's not my place to kind of give their good news. So the paranoia registry, you know, don't be paranoid. Let's improve outcomes through better understanding of pancreas fistula. Some surgeons are very robust, and they're not paranoid at all. And some surgeons are very strong in their opinion that they have very good outcomes. But I think most of us recognize that clinical scenario where we operate on two patients with very similar characteristics. One patient has a leak and a terrible outcome. The next patient doesn't leak. And we don't understand why we've got that. We know what a high-risk patient looks like. We know what a low-risk patient looks like. But why does, you know, one high-risk patient leak and the next high-risk patient not leak? And that's where I hope we're going with paranoia. So it's an international registry, and the primary purpose is to provide surgeons with their own individualized pancreas fistula outcomes, and in particular risk-adjusted outcome. But it's also a platform to explore fistula risk factors and potentially conduct clinical trials. We all know what the so what is. Pancreas fistula is the leading cause of morbidity and mortality after this operation. And if we look at data from the UK of 15,000 Whipples, we have a 90-day mortality of 6.5% if we go back 5 to 10 years. We're currently at a 90-day mortality rate of 3.5% in the UK, and this is pretty similar to other national data. So we have an operation that has a higher rate of mortality than elective cardiac surgery, from elective other major vascular surgery, and so on. And we know from this nice study by Chuck Vollmer and colleagues that, you know, the root cause of mortality is the fistula. So why do we need a new format? So Giovanni and the team have done absolute wonderful work in defining pancreas fistula and then refining the definition. And ISGPS, I think we all need to be very thankful for, because we have a common language. But we have little understanding of surgeons' outcomes. And I don't mean this from me looking at your outcome. That's not what I mean. What I mean is, as an individual, I don't really have a handle on what my data looks like. I know what my crude fistula outcome looks like, but if I risk adjust, or if I compare myself to my peers who are, of a similar age or similar career volume, where do I stand? We don't have that. We also don't have a tool that allows us to look at the impact of changing technique upon our outcome. We don't really know what the optimal outcome is, optimal technique is. And I'm going to put it to you, and I'll show you some data that I don't think we've got a good track record of randomized trials in this field. So let's look a little bit data of surgical outcomes. So this was again by Chuck Vollmer, and it looked at 15 institutions and 55 surgeons from around the world. And they performed some risk adjustment using the FRS. And what they showed is, perhaps unsurprisingly, that most institutions performed as expected, some performed better than expected, and some performed worse than expected. And the problem here is they didn't actually tell us what the characteristics of these institutions who did badly or did well were. So there wasn't a lot of learning from that study, and they did provide individual surgeon level data, but it's the same features. We have some people doing better than expected, some doing worse, but we don't know what the characteristics are of those individual surgeons, because if we knew those characteristics, maybe we could have some learning from it. So why do we need risk adjustment? Well, risk adjustment's really important. So let's show our dirty laundry from Birmingham. So this is a paper that we published not so long ago. And at that time, we had 3 experienced surgeons in the unit, and we had 5 newly appointed surgeons over the few years preceding the study. And if you just look at crude fistula rate, it's clearly different between the experienced surgeon and the newly appointed surgeon. This is all POPF, not clinically relevant. So we've got 11% versus 25%. A huge difference. We're all operating on the same patients. Now, let's say you're the boss of the unit and you're presented with this crude, non-adjusted fistula data. Here we have a new surgeon, and here we have an experienced surgeon. What do you do with this? Do you stop the new surgeon operating? Do you go and sit in theatre and watch him or her? Or do you give the experienced surgeon a pat on the back for doing such a wonderful job? Well, what you need risk adjustment. And with risk adjustment, with a QSUM type analysis, actually what we see is that, yes, the experienced surgeon is the outlier because they have far fewer fistulas than expected. And although there was a slight excess of fistula early on, actually the new consultants seems to have got on top of things pretty quickly, and the QSUM looks pretty healthy. And these are individual QSUMs from the 8 surgeons in the unit. And you can see that the 3 experienced surgeons have a pretty similar QSUM characteristic, whereas the new surgeons, it's a bit more erratic, and the strong performance that is consistent is not quite there yet. The other thing that you can do with a QSUM is you can look at the change of technique. So here is the overall QSUM at the top, but below, what we can do is we can reset the QSUM to 0 when there's a change of technique. So we see here that this surgeon had 3 fistulas and changed technique to a second one, had a run of 4 fistulas, but then stuck with that one and actually was doing pretty well. And then for reasons that are unclear, swapped to a 3rd technique. After a steady state, acquired characteristics similar to one of the experienced consultants. So quite a nice QSUM. This is an interesting set of data. So this colleague actually has 2 different techniques. And so he uses one technique for a high-risk gland and one technique for a low-risk gland. But what you see with risk adjustment, he has a slight excess of fistula when he operates on his high-risk technique. So is it that technique is not quite as effective, or is it because he doesn't perform that technique quite so often as he does with the other one? So you can look at this data you can interrogate it in ways that you can't normally interrogate your fistula outcomes. And if you look at the average QSUM plots for the new surgeons and the experienced surgeons, you see a nice evidence of learning curve. So the primary purpose of paranoia will give surgeons that level of data, and you'll be able to risk adjust, and you'll be able to look at how your practice changes over time. And if you change your technique, you can see how that affects your outcome. Importantly, you'll be able to benchmark yourself against your peers. Everybody will be anonymized in the database, but if you want to compare your outcome against everybody else's, you can. If you want to compare yours against people of the similar age or career experience, then you can do that. You can also look at different operative factors, PG, PJ, one layer, internal stent, external stent, and so on and so forth. None of the surgeons, none of the institutions will be identifiable. So what data goes in? So not a huge amount. When a surgeon signs up, they describe their operative technique, and we've, with the permission of the Dutch, we're using the same way that is described on the Pancreatic Anastomosis website. And then the patient factors, we don't need many patient factors to give an FRS, the AFRS, or the Birmingham risk scores. All we need is age, gender. The estimated blood loss is optional. The FRS has moved on to the AFRS, and the estimated blood loss has dropped out. But because the FRS is so well known, we've kept that in, but it is optional. Duct width, body mass index, if it's hard or soft, if there's neoadjuvant therapy, and the pathology. And that allows us to do risk adjustment with 3 scores. We recommend that you put the data in at the time of surgery, it doesn't take long, and then you have an email reminder to complete a very short set of outcome data up to 90 days. So what about paranoia as a platform for trials or studies? So what's wrong with randomized trials? Well, it's predominantly a question of power. So this is a really neat study performed by Rupley and James Halley-Smith and the rest of the trainees. And what we did a systematic review and a meta-analysis of all randomized trials looking at pancreas fistula. And then it's a cheap trick really, but we did post hoc power calculations based upon the observed rate of fistula in the control group to power the study. And if you look at the figures on the right-hand side, the black diamonds are the actual sample size. And then if you wanted to power the study to see a 75% reduction in fistula, or a 50% reduction in fistula, or a 25% reduction in fistula, you actually needed the sample size that you see on the x-axis. And what you can see is that almost all studies were woefully underpowered. And if you go back to the summary of the data in the table on the left, for trial studies of clinically relevant fistula, you need to observe a fistula rate of less than 1% in your intervention arm in the majority of those studies to have seen a significant difference. And that's clearly unrealistic. And the median study size was just 110 patients. So that's 55 patients in control, 55 patients in your intervention arm. You can see there are just not enough numbers here to do a randomized trial. So you could say, well, if power is an issue, well, let's use meta-analysis. So let's look at the example of PG versus PJ, one of our favorite topics. So here's a meta-analysis from 2015, 6 randomized trials, 1,000 patients, summary, PG better. Let's go forward a year. We've added 2 randomized trials, 1,200 patients, the PG is still better. For the same year, we've now got 10 trials and 1,600 patients, and PG is superior. Remarkably, in the same year, with the same trials and the same number of patients, this meta-analysis said there was no difference. Presumably, they used a different technique of meta-analysis to do the data assimilation. If you come forward a year, PG is better again. And if you then look at the same set of data, but in another way, we see no difference. So I'm not sure that meta-analyzing small trials in this field is really going to give us the answer. And from another meta-analysis from the group, 55 studies of 7,500 patients testing 22 interventions, only one intervention, and it's interesting what the data that Giovanni showed, only one intervention reduced all and clinically relevant pancreas fistula, and that was external pancreatic duct drainage, but not large numbers of patients, 371. Ulinistatin reduced clinically relevant fistula, but only 132 patients in total, and invagination versus ductal mucosa PJ reduced all POPF, but not clinically relevant POPF. So many studies and not a lot of positive data from meta-analysis. There are other problems with randomized trials. You know, how long does it take to design a trial? How long does it take to get the funding? And even a high volume pancreas unit is not really that high volume. So how long does it take to recruit those patients? How generalizable is data from a randomized trial? And how do you come inherent confounding when a surgeon may be more familiar with one technique over another? And then there's all the issues of blinding in randomized trials and so on. We could talk for a long time about methodologic problems with surgical trials. So paranoia as a research tool, we have a network of surgeons throughout the world putting data in prospectively. We could analyze what data is in the registry, and we would propose that as a level 1 type of analysis. So for example, PG versus PJ, we can do that. If somebody wanted to look at the role of CRP post-operatively as a prediction tool, CRP is not in our data set, but for a period of time, we can give surgeons the option of adding that data in if they want. And so we can run time-limited prospective observational studies through our platform. If we have a power, then we know when we've finished and we've recruited enough patients, and we simply close that extra data set. But looking forward, why do we not even think about performing clinical trials through this platform? You know, TWIX trials within a cohort are novel, they're highly cost effective, they're flexible. So the benefits of this would be, you know, it's international, there's transparent processes, collaborative authorship, recognizes participating surgeons, and it also allows people who don't normally publish or not normally research active to have, you know, to have some power and to be active in this field. We have a steering committee to oversee and ensure quality, and we're looking to grow this and grow friends and support as we go. There's also paranoia for trainees. So another nice systematic review meta-analysis from the group. Trainees appear to have very good outcomes when they perform pancreatic anastomosis. But what we saw, unsurprisingly, is that trainees operate on low-risk glands. So we would expect them to have good outcomes. So here we really do need risk adjustment. And what you can see on the right-hand side is a risk-adjusted analysis. And actually, although the trainees have got, what, 1 extra fistula, it's taken 70 cases to get there. And you can see that they're performing very well compared to consultants. So if trainees can use this, they can build a logbook, and actually the trainee version of paranoia will allow them to capture more parts of the operation, and it's a much more complete thing to describe their evolving and improving experience with surgery. So we have an international steering committee. We have endorsement from the EAHPBA, and we're seeking endorsement from IHPBA. The systematic reviews and meta-analyses that the team have performed have really shaped where we are. This is an overview of the whole process, and you know, just a really big thank you to Rupli for all the huge amount of work that she's put in. James Hallis-Smith, Lewis Hall, and Steve Knight also key, as well as the other trainees, and thank you to my colleagues in the steering committee. So thank you for allowing me the time to speak. I'm sorry I haven't given you the answer to mitigation of strategy, mitigation of pancreas fistula once it's happened. I wish I knew how to tell you we could do that, but hopefully this gives us a new way to look at this. Thank you.
Thanks so much, Keith. That was a great overview of the paranoia study. So should we open the floor to the panelists, Marcello and Anita? Marcello, would you want to start with any questions you have for Keith or Giovanni?
Yeah, I'd like to. So thanks to both speakers for the very nice presentation. And so, I mean, I think there are 2 key points about the story of pancreatic fistula during the last few years. So one is the decrease of post-operative pancreatic fistula through, I mean, thanks to stratification and mitigation strategies. This is preoperatively and intraoperatively. And the other one is the decrease of the failure to rescue of these patients and the decrease in mortality So these are the two main issues. So first one, it could have helped stratification, centralization, and getting more experience and individualized management of these patients. And this has been nicely described by Giovanni. And the other thing on this topic is the importance of preoperative meeting analyzing these patients. And the other one is the failure to rescue. So what to do with these patients. So I would like to ask to both speakers, what do you think are the pillars of these two things? I mean, Giovanni has gone through all the stratification and mitigation strategies, of course, but practically, what do you look at, this is for residents, in your preoperative meetings, apart from BMI, et cetera, technical things that you look at in the preoperative meetings? And then after the operation, what do you do for this borderline patient, the one with the fistula, in order to decrease the mortality? Routine CT scan, when do you start, if you start using antibiotics, et cetera, et cetera. So basically, what are the key points of these two things?
Keith, you want to go first, Keith, or should I?
Yeah, sure. Okay. So I think when it comes to post-operative, there are two things that we can do. I think the data is quite clear that infection is the key to a bad outcome for most fistula. Infection will precede bleeding from pseudoangioplasty, sepsis. The data from the Dutch trial, tells us what to do. It says, look at these patients in close detail. And I think if we all simply put our focus onto those post-operative patients, we'd have better outcomes. That is probably my take-home message. And in the UK, for example, and I have personal experience of this in the past 2 weeks, we send people home early. So I had a patient, Amylase was 790 on post-operative day 1, but it dropped quickly. We took the drain out because by day 3, the amylase was low, and he went home on day 7. He looked fine, but he was readmitted with bleeding to his local hospital, transferred across, had an angio, and had a stent for his pseudoaneurysm, but had a cardiac arrest in ITU and died. He went home on day 7. Now, in a lot of hospitals around the world, there isn't such a rush to get people out, and had what happened to him, had he been in hospital on day 12 when he had his event, the outcome might have been different. Or had we had a protocol in place to look at CRP and to look at, regular use of CT scan, the outcome might have been different here. And that example is, I don't think, that atypical.
Yeah, I totally agree with Keith. If I have to resume the key points of this great question by Marcello, I think that, first of all, I would say rely on protocols. They are fundamental to standardize your practice. The importance of the team, because as Keith pointed out, you can be the most skilled surgeon, but then when you're on POD3 and your patient is bleeding and your best friend becomes the angiographist, can really save patient's life. So I would put an accent rather than just on a surgeon, I'm sorry, but on the team. So I would say to have an entire dedicated multidisciplinary team taking care of your patient. And in this regard, I would put an accent on having young and talented doctors like residents are, because a true factor is having someone who's 24/7 on your patient. There's really increases the quality of care if you have these doctors always, around your patient. Pancreatic patients are really demanding. You can check on them every 10 minutes and they can completely change their clinical scenario. So that's another key point. And then final message, be ready to update your knowledge, to change your dogma, because as I showed you before, pancreagastrostomy was assessed, at least in Verona, by Claudio Bassi, and he was the same one who actually helped us in doing the trial that eventually concluded the end of this anastomosis in Verona. So I think this is very clever. So be ready to break your dogma and update yourself year after year. Those would be my key messages.
So I mean, keep going with practical cases, basically, to make this even more clear. So 2 examples. You are on day 7 of a PD. So the patient is doing well, but he has a biochemical leak so far. And then on day 6, 7, 8, the CPR goes up, inflammatory markers goes up, you do a CT scan, and you see that there is an additional collection, 5 centimeter per 5. What do? Drain, antibiotics, nothing. And this is on day 7. Something on day 28, 30. Patient has been in hospital for 1 month with a pancreatic fistula, grade B, antibiotics, drain, now it's doing better, but still has the same drain in place, the one you put during the operation, and there's still this leak. So what do you do with this drain? Do you leave the drain, mobilize the drain, change the drain?
So I think for patient 1, I would give antibiotics and I would ask my radiologists if they can drain the collection. So that was a day 7 infected looking collection. And for the other one, you have an established fistula. So then you're into the realms of nutrition and support. He or she is kind of out of the danger zone in terms of bleeding. We know that bleeding is really, day 12 to day 21. And he also seems to be out of danger zone in terms of sepsis. If he was going to fall apart from, a bad leak and collections everywhere, he would have done it. So I think you've got a controlled fistula. And so nutrition, and then consider starting to withdraw the drain bit by bit if they're well. Would be my thoughts for those.
So as for me, I mean, I'm in line with what Keith just said. For patient 1, I probably would ask, if a patient on POD7 has a biochemical leak, I would ask myself, why this patient is still here and he's not home? Because, I mean, as a matter of fact, you pointed out that afterwards the patient developed a collection, but, I mean, we know that you
patient was fine.
Patient a biochemical leak with a biochemical leak on POD7. So probably that would be my first provocatory question, of course. And then in terms of managing long-standing fistula, we know that this is very painful. So again, when it comes to the use of antibiotics, we surgeons are pretty bad, I would say. We're good in selecting, super resistant bacteria. So we have to be very strict on that. We have to, sample blood, all the fluids in order to be as more, selective as possible. We like to move drain in Verona. So about your question, Marcello, what to do with drains? We usually don't keep drain in the same position for longer than 3 days. We don't want them, to do bad things on the colon, for example. We like to change them, particularly if you're not happy with the drainage of a collection. We use the so-called step-up approach, like, using the Dutch model. So again, it comes to the radiologist, to substitute your drain, and we can, do that with, bigger drains. And but again, this is very, I would say, depending on a specific situation. But yeah, I mean, late bleeding, as Keith pointed out, are a true issue. And I would say that we try to be as much conservative as possible, because when your patient is developing a fistula and you are, late in your POD, that you go to laparotomy just in very selective cases, but that your outcome won't be good. So another key point is try to be more conservative as possible. It's awful to go back in a belly on POD 30 with a fistula ongoing.
Thanks. So, I mean, I would have more questions, but I would leave the stage to the other.
Going back to your example, Keith, your patient that went home quite early, and this is for Giovanni as well. What experience and what feelings do you have about patients going home with drains in situ and coming back perhaps a week later for reassessment, if they're clinically well?
So I think that the learning message is the difference between a head resection and a tail resection, and the danger period. And this always goes back to pseudoaneurysm. You know, sepsis declares itself very clearly. You know what sepsis looks like, and you don't send a patient home who's septic, and they rarely come back in a heap because of sepsis. They come back in dead or dying because of pseudoaneurysms. And you only really see it with leaks from after a head resection. You know, it's very rare with leaks from a tail resection. So I think it's very common in my practice for patients to have a leak after a distal, and they tend to go home with their drains, and they come back to clinic. But with a head resection, I really do think we need to be very careful about, you know, sending people home early. And I really do like the Dutch study. It really places a focus upon CRP, on scanning and draining, and their data is clear. They've reduced mortality, and that's, you know, this is big stuff. We have, as I said in my talk, we have a higher mortality than elective, you know, cardiac surgery and so on and so forth, and we really need to do something to make that better.
I'd agree. I think that Dutch algorithm from their paper is amazing. Very easy to follow for everyone. Definitely. Anita, do you have any questions?
Can I add something, Adam?
Go on. Yeah, sorry, go on.
Yeah, I mean, I love the question. So, I mean, because it actually made me thought about the update of the fistula definition. So imagine myself with all these, you know, big guys of the ISGPS trying, you know, to avoid, you know, fighting between them. And then we came with a definition, and I was very happy, of course, after, you know, 2 years of this, you know, of dealing with this. And then they asked me to change the original definition, because if you recall it, being discharged with drain in place automatically made a fistula becoming a B, because at that time that was clinically relevant. But with the rise of minimal invasive technique, as Keith pointed out, it's now way more common, you know, to safely discharge a patient with drains in place. So this was, I would say, a leak of the definition, which has to be changed because, of course, you know, our technique evolved. So also definition needs to evolve. Otherwise, they don't picture the actual clinical practice. So we discharge, as Keith said, patients with drains. But then this comes to another problem, which at least in Italy is, I would say, very relevant, which is the lack or the importance, I would say, of infrastructure for these patients, you know, to be dealt not just in the ward with a critical patient, but not even at home. So you need to have a system which is able to assist you. Because when I used to work in the United States, I was astonished by this short length of stay that they had, just because they had such beautiful infrastructure where the patient, you know, had time to recover, but the patient was not at home. And imagine how difficult that is for us, that we are the national referring center in Italy, when we have a patient coming from Sicily. I mean, can we discharge this patient and let him take, or let her take, a low-cost flight to Palermo? I mean, this, of course, is not doable. So that's why we also started not to trust the length of stay as a metric, and we like time to functional recovery most, because this is really something that you can trust more than length of stay.
So yeah, may I say something on this? I think this is extremely important, because having worked like in Italy, in Spain, and in the UK, a bit in the US, that's extremely important, because I mean, the likelihood of being readmitted quickly in different places is very different. So you need to adapt your strategy according to where you are and what you have. Yeah, 100%.
But this is the beauty of the paranoia study, isn't it, Keith? You're going to tell us exactly which country has the best length of stay, which surgeons, which country you know, has the highest fistula rate. Can you enlighten us?
Could, if I could unmute the bloody thing quicker. So I can't tell you yet, but I know that within 6 weeks of opening, we have surgeons from 40 countries and 150 surgeons signed up. So, you know, I think it looks good. And I think, I'll give you a practical example. In the unit, I do the same technique as, you know, one of the senior surgeons, and I copied it from him because he's got such good outcomes. And we both do the same technique on paper, but his outcomes are better than mine. You know, and you have to put your hand up and say say that. So I don't think it's a case of PG is better than PJ or 2 layers better than 1 layer. You know, what is best is what works well for you. And Darius has learned his technique over years. He's refined it. He's, you know, he's wonderfully experienced liver transplant, small bowel transplant, pediatric surgeon. He's fantastic. And, I can see through my QSUM plot that I'm improving as time goes by. And maybe when I'm, as towards end, at a similar stage of my career as Darius, maybe my QSUM will be the same. So I don't think it's, is one technique versus another. It's what works well for you.
I had a question actually.
Oh, yeah, go Anita.
So I preface that by saying amazing talks, and every time I link into the TUG session, I learn so many new things. So that was really good from both Giovanni and Keith. Thank you very much. I just wanted to ask Giovanni, actually, your risk stratification score was really interesting. Can you break that down further? So can you explain why you think, or why you found the ASA to be related to post-op fistula risk? And within the subcategory of main, I think you said main pancreatic duct of less than 5 millimeters, there was an increased risk. Can you break that down even more? Can you say how the risk changes if it's less than 2 millimeters versus 3 to 5 millimeters, for instance?
Yeah, of course, Anita, but then you also want to be practical, right? Because I don't really think that a millimeter makes a difference. I mean, what I don't like about the fistula score is this 1 or 2 millimeter thing. Another thing I think should be criticized is the estimated blood loss. So it turns out that we all care about blood loss, but then if we ask the audience how they assess blood loss in the OR, I'm pretty sure that we're gonna find some very interesting answers, and we practically use different methods, to estimate that. Usually a surgeon is kind of, estimating her or his blood loss I would say in a different way. But yeah, I mean, I think that the key message, Anita, is here. So the more we approach to the complication itself, which is POPF, the more we become accurate. But then we are in a hurry because, when we get closer to the complication, we have less tool. So it's very tricky, and it's very important to start your risk assessment as soon as possible. So as I showed, even before the surgery itself, but even after the surgery, you have another window, which is between the operative room and the occurrence of fistula. And that's why I wanted to also tackle acute pancreatitis and hyperamylasemia as an additional tool to refine your risk assessment. So the key message is you can start when you see your patient by calculating the duct size, the BMI, the SAA, as you said. Then if you're forced to go to surgery because you have to do a Whipple, then in the operative room you have other tools to assess the risk. But even afterwards, and you of course change your management, you can again define the risk the more you get closer to the complication. This is very dynamic as a process, but I think that this leads to better outcome, as Keith pointed out, with such fine analysis as the paranoia study will provide. But it's just a shift in the mentality. It's not a static thing. It's not a picture. It's like a movie, okay? And this dynamic risk assessment, I think, is key to have better outcomes.
I think there's some nice questions coming on the chat, actually. There's one question I think is good for Keith, actually. Do you change the timing of oral intake according to the risk of pancreatic fistula? I don't know if you saw that one from Narcis Zarnescu.
So yeah, that's a great question, and it's one that we're thinking about in a slightly different forum. So we're looking at perioperative nutrition now. Dogma is when you have pancreatitis, when you have a pancreas fistula, you don't feed because you don't want to upset the pancreas. But actually, we all know that is probably not true. The main trigger for pancreas secretion is the release of cholecystokinin and VIP from the duodenum. Well, that's in the bin. So the other trigger for pancreas secretions are the autonomic nerves running along the GDA. Well, we've tied that and cut it into two. So actually your pancreas remnant in a Whipple just sits there and it can't really stimulate the bloody thing. So I don't think that feeding makes a fistula worse. And James Halley-Smith, who I spoke about, has done a systematic review and meta-analysis on this very recently, and the available data suggests that it doesn't make it worse. But small numbers from the trials, but it would make a very neat trial. Pancreas fistula, you know, day 3, day 5, grade A, what do you do? Do you feed at will or do you go slow? I don't think it makes it worse.
In Guildford, we routinely put nasovaginal tubes down, and if there's a leak, fistula, we tend to use those. Does anyone else have experience like that? What do you do in Birmingham and Verona and Cambridge?
We do the same.
Yeah, in Bristol as well, we stick a nasal ejection tube down as well in surgery. But we have quite a low threshold in starting TPN as well. But that basically goes against what Keith said, that it doesn't really matter if you not feed them or don't feed them. But we think, you give them TPN to give them a bit bowel rest and such. But I don't know what other people do. Giovanni?
Yeah, again, I mean, we do the same. But while it's pretty obvious that we can orally feed our patient since the very beginning, we learned it from the ERAS protocols. So in Italy, we try to bring, spaghetti or pizza, depending on where the patient is from. But I think that the real question, we still have no evidence at all, is what to do when the fistula is starting. Because the first reaction is to try to avoid, feeding the patient. And the evidence now becomes, less and less. But at that time, it's not really clear whether you have an advantage in shifting into total parenteral nutrition or going with enteral, because we know that you can orally feed your patient at the very beginning. We have trials on that, at least 2. But at this, I would say, later phase, it becomes, I would say, less evident what's the best practice.
I think the problem that we seem to see in Cambridge quite a lot, I don't know about everybody else, is the fistula tends to cause delayed gastric emptying. And that's where your problem starts, because I don't think it makes the fistula worse to feed them, but I think the fistula forming certainly stimulates the delayed gastric emptying, and that's when you usually need some, NJ feeding, etc. So we do sometimes place NJ tubes at the time of surgery for particularly high-risk patients. I wouldn't routinely place it. Sometimes they pull it out overnight, so that doesn't help. So it's one of the reasons we don't do it all the time. But I think the bigger problem we have is that they have delayed gastric emptying whenever they get a fistula, or very frequently. And that's the issue that delays their feeding, I think.
Yeah, I agree. I see that a lot as well. We see that a lot. Do you have a delayed gastric emptying after obviously fistula? One place in the Netherlands I worked, we used to get a little Prolian and stitch them in the nose to prevent people from pulling them out whilst they were delirious, because they would hurt themselves. But you obviously have the dislocation of your tube as well when it just curls up into the stomach if you don't put it in far enough. So the little stitch in the nose won't help with that.
I completely agree. The Rashid on the chat has commented actually that post-operative day 3, if the Ryle's tube has not shown ileus or gastric outflow obstruction, then you can start feeding them. That's kind of, yeah, that makes sense. But actually what Rashid set up at the top there, I don't know what the question is, but it says isolated limb technique can reduce the risk of post-operative pancreatic fistula. One limb for the PJ and a separate limb for the HJ, and then a jedge. What do you think, Keith and Giovanni, about an isolated limb technique? I know that Professor Davidson still does that at the Royal Free. Any comments? Not about Professor Davidson, but about the...
Yeah, I think Whipple's operations take long enough without adding more joins. So from the data from randomized trials and the meta-analysis is that there's no advantage. I think Rashid then said it works well in high-risk patients. So I'm not sure, but again, maybe it's one of those scenarios where a risk adjustment will be quite neat. You could risk adjust your patients and see actually if there is a difference between low risk and high risk. But I'm not aware of data that says it's superior.
Can I comment, please?
Oh yes, please.
Actually, it is needs a lot of training in order to start doing isolated. That's what I found.
Sorry, could you say, Rashid? Could you please repeat that? We just couldn't hear you. It was a bit quiet.
Sorry for that. It needs sometimes in order to become familiar with the isolated limb technique. So one limb for PJ and another limb for HJ. And then you add the fourth anastomosis, which is JJ. it helps to reduce the reflux of bile into the BJ, okay, because you are separating between the FJ and BJ. So this is what one of the mechanisms which can reduce the risk of pancreatic fistula. Another things which is mechanical agents like using TC, the other agents, which helps to fix the ileal jejunal limb to the pancreas, and also if you can apply the falciform ligaments, attach it on top of the anastomosis. Yeah, we find these also help reduce the mechanism of the risk of pancreatic fistula.
Oh, thank you for that, Rashid. I think, yeah, I mean, Professor Davidson's got very good outcomes after his Whipples, but I always got a bit confused about different loops of jejunum going all over the place. And you know, there were a few patients that had a mechanical twist, you know, and problems. So, falciform patch. Does anyone use that routinely? Falciform ligament patch to the PJ. Professor Roberts, when did you start using that?
Well, it hides the nasty anastomosis, so you can't see it at the end of the operation. So it must be good. If you can't see it, then happy days. But I mean, it's being serious. It's one of those things that it's in paranoia. You've got a tick box for that. You've got a tick box for your isolated root limb. So all these technical features are in paranoia. You know, in 1,000 cases, 2,000 cases, 5,000 cases, we can come back and we can look at this stuff. So I keep plugging paranoia. I'm sorry.
Oh, definitely.
Keith,
Could be a great resource, like you say, in a couple of years' time.
Keith, do you have in paranoia also a box to, you know, to think if you use the only way to avoid like 0% risk of pancreatic fistula, which is avoiding doing anastomosis, so going for a total, because I saw in the chat box that there was this provocative question. So maybe you wanna comment on that. We're not in the US, so no one is gonna throw, you know, tomatoes on us.
Yeah, it's a good question. So no, it's not, because paranoia is just for Whipples. So if you've done a total, it doesn't go in. But yeah, I mean, I know some people do that. They have an awful looking pancreas and they get to the end of the operation and they think, right, that's it. It's going. It's looked at me in a bad way. I'm not having this anymore. And out it comes. It's not something I do, but yeah.
So now, that's the same question. How many of you guys do consider total pancreatectomy after sort of uncontrolled leaks to sort of deal with the problem? Do many people do that?
So I mean, then I think the nice thing with a completion pancreatectomy is it's much less frequently performed now than it was, and that's you know, thanks to our interventional radiology colleagues, and thanks to, you know, the recognition of, you know, failure to rescue. I don't know about you guys, but it's very rare that we go in and do a laparotomy now for post-operative complications. And the problem is, if you do go in and do a laparotomy for pancreas fistula, it's very difficult to leave the bloody thing behind.
Can I comment on that? So we really wanted to assess this question because for years we didn't even, you know, think about completion pancreatectomy for the high-risk pancreas. And with surprise, we found that from prospective data, our total pancreatectomy, I'm talking about now morbidity and mortality, not talking about quality of life, diabetes related, actually are doing, you know, better and better above the years. So I know that this has been brought up by the Heidelberg group, for example. Also because total pancreatectomy is not a single operation. So if you perform it for oncological reason, then of course it's a, you know, you have splenectomy, you want to sacrifice vessels. But if you do a completion, keeping the spleen, keeping your left gastric, it becomes a less invasive procedure. So I think that, again, to start talking about this is mandatory to consider only the high-risk cases. So no one of us, of course, would ever consider, you know, total pancreatectomy, you know, when the anastomosis is feasible. But when it gets to invisible duct, fragile stump in diabetic patients, then I think that it's less obvious, you know, that we all would go for an anastomosis, particularly in those cases. And now that we're running a trial on that, we see them more and more, maybe because we pay more attention. Consider the low tumors in the uncinate, leaving the pancreas, you know, very soft with small duct in patients requiring adjuvant chemo. So in those cases, you really want to avoid horrible fistulas. So at least in this case, I think we should, you know, try to assess this issue in a randomized fashion, because I mean, with the advancement of technique, the answers become less obvious. So we're now opening to this, but again, only in very selected cases, and we want to assess also the quality of life, because that's of course very important. We already know that the diabetic scores, you know, for quality of life are actually decreased with total pancreatitis. So this is an open, I would say, debate, and it would be nice to see, you know, new adding evidence in this regard.
It's difficult, you know, with the total. I mean, the high risk groups are often your soft pancreases in the IPMNs and such, and you know, these are the people with the longest sort of. I mean, they will have normal lifespan in theory. So you're basically exposing them to the worst kind of morbidity if you do it up front, and that's always such a difficult decision, I find.
So may I make another comment on these high-risk patients? So one is more for Giovanni and the other one is more for the paranoia study group. So for the paranoia, so one of the variables you are collecting is the texture of the pancreatic stump, so hard or soft. But I mean, we are trying to find objective definition of everything, but this is highly subjective. So do you think this could be assessed by the paranoia study group, either by radiomics, preoperative radiomics, or other things? And for Giovanni, so these high-risk patients, so you spoke a lot about the kind of new definition of post-operative post-operative pancreatitis, and then you've done some research of the epidermal growth factor on drains, etc., etc. So what do you do with these patients? This one high risk, we do practically again. So more blood tests, low threshold for antibiotics. So what do you do?
Keith, you want to go first, or should I?
I'm always going first. I feel bad, Giovanni.
Okay. So, I mean, in this case, Marcello, I mean, once again, the total pancreatectomy is an option that we do not consider routinely. And if we assess the risk in the OR and this comes extremely high, we now do PJ with all mitigation strategy. We put jejunostomy, so feeding tube, we put an external stent, we always put drain. So we label this patient at high risk. So we put an eye on him, okay? We do not routinely, you know, avoid following URAS policy, but those are the patients, you know, less likely to follow them. And we basically get ready for complication. We expect them. So I think that getting prepared to something to happen is the fundamental thing, not to be surprised by of course, it all can always happen. So yeah, these are basically what we do. And but as I said, Marcello, if you know you keep on updating the risk day after day, you become way more detailed, because we notice, for example, that those soft pancreas with small duct usually have a peak in the amylase in the blood in the first hours. If this peak becomes sustained, then again you want to hyper label this patient even at higher risk. So probably in this patient, you might want to slow down with oral feeding. You know, you want to keep your drains, you know, for more days. Again, we're learning from these cases, you know, year after year. And also thanks to registries like the paranoia, probably will do better, even more.
And yeah, thanks, Marcello. So yeah, soft versus hard. I mean, it's an entirely subjective variable. And if we're going to be scientific, we need to ditch things that are subjective. The reason it's in there is because you need it for the AFRS risk score. So we can't do the risk adjustment without that variable. But it would make a neat study to see if there is a harder surrogate that you could use instead. But, you know, if you look at most studies that look at pancreas fistula, hard versus soft, you know, it comes out. So, yeah.
Can I add, Keith, a little comment? So back in the day, I wanted to assess this in a objective way. So I came out with a tool which was called durometer. So don't laugh, it's the actual word. So of course my boss made fun of me. What are you measuring with this tool? Whatever, you know, or jokes. But this tool was great because it was actually a plier, you know, being able to, you know, objectivize how hard or soft the pancreas was. And then I learned from, you know, my friend, my fellow from the physics department that what we're measuring is definitely not what is hard or soft, but it's a surrogate of what is the surgeon's feeling. So of course, by palpation, you can try to objectivize whether the pancreas is soft or hard, but basically your brain is already defining how you feel about the likelihood of having a fistula. So at the end, you know, I was able to finish my project, which was, you know, not a groundbreaking one, but, you know, it's in there, it's on PubMed. But again, the surgeon's experience, which is the capability of defining a risk, we say soft or hard, was the best predictive model, but it's not probably an objective way to say whether a pancreas is hard or soft. But we keep the, you know, the terminology, and we like to say this pancreas was soft or this pancreas was hard.
There's the post-operative excuses we all start to make.
No, it's true, isn't it? It's this was soft, this was horrible. It's definitely going to leave. It's like, you know, I've definitely said that a few times.
So a question about the pancreatitis, Giovanni. So when you see that there's a high amylase on day one of the surgery, do you change your treatment of the patient? You change your management of the patient straight away, and how?
No, not straight away, because this has been assessed while we're talking.
Yeah.
So we just had a definition. It took years to have a definition. To get actual pancreatitis, you also need radiology. So this is, you know, difficult because you know that as in the normal acute pancreatitis, the changing, you know, takes place afterwards. So at the beginning, you just have some edema, which is kind of, you know, physiologic after a Whipple resection. But we definitely now readjust the risk according to this post-operative hyperamylasemia, POH is defined, because it turns out that it adds value to the fistulary score. So we're now routinely assess the amylase in the serum hour after hour for the first 2 post-operative days, and in this way we are refining our ability to assess the risk. So yeah, so it's definitely worth to do that. So if you are not routinely doing it, I would suggest start doing it because it provides great insights.
Hour by hour. The serum amylase. We're going to be spending a lot of money on serum amylase.
Yeah, we're now starting to do it even in the operating room, because our hypothesis is that even like by palpating the pancreas and then cutting it, you're able to detect some variation. Yeah, so I don't know if this is now clinically relevant, but definitely we have a lot of interest in seeing how these curves change. It's pretty clear how these change, also based on how florid your pancreas is. You know, when it gets to soft pancreas but with low acinar and you know a less, I would say, exocrine function, then you know doesn't really matter what you do. Those pancreas is not going to leak even if it's soft.
Could you hint at the you know the peak, the time of peak, you know, the best hour to measure the serum amylase?
If you do it on POD1, you can clearly see the start of the peak, but it's crucial if this just go away after 6 to 8 hours, or if it stays until POD2. If they remain elevated for 2 days, then those are the most risky cases. These are again preliminary data. I mean, this is something very new. It's out there since just 1 year or so.
So another question is about sort of the high risk patients that actually do quite well, and I think Keith, one of the cases you mentioned, the patient of yours who unfortunately got readmitted with the bleed. Would it be because, and also because of the poor strong app that came out in the App Store about predicting when do you do a CT scan, when do you don't do a CT scan in the post-operative management. and it's basically a question for both the speakers and all the panelists. Is there sort of a role to say, well, it's a high-risk pancreas, but when the drain fluid amylases went down quite nicely, patients actually doing quite well. Do you still think maybe we should do a routine scan in that subgroup of patients just to make sure that there's nothing like a drain has slipped out of place and there's still sort of a small collection brewing, and we could then potentially prevent something worse happening in the community when the patient goes home?
Yeah, it's a good question. So I think a global view of the patient, what's the CRP doing, what's the white cell doing, what's the temperature doing, and what do they look like? But there's no doubt, that little collection that you see on your CT scan around your anastomosis, that's where the trouble comes from.
We tend to do a CT triple phase before they go home for patients who have a known leak, as you know, Stein, because we're paranoid like that. And it has on more than one occasion, even recently, picked up these things and, potentially bleed and or death averted. So that's something that we do quite often, but we don't routinely organize a CT scan unless they have a leak and you're leaving the drains in.
There's a comment on the chat again from Lucas Mazio. This is regarding what Giovanni was saying. What do you think about frozen section assessment of the pancreatic margin with regards to gland fibrosis for your soft and hard definition?
The Finnish had great experience on that. We like it. We think it's reliable. Only with our pathologists, we usually fight, whether, to be clear if the frozen section is positive or negative. So we don't like to add too many information, too much information at this stage. So probably it's a little too much, to be asked, but it's definitely a score. There are multiple scores, particularly the Finnish use them, and they look to be reliable.
Could it be a study, basically? You say, well, the surgeon says soft or hard pancreas, and then later on in the pathology, they confirm by a certain measure if it's really soft or hard, because that could maybe sort of make it a bit more reliable, the touch of the surgeon.
There's also that concept, Giovanni, of treating patients post-pancreatic surgery with high-dose steroids, wasn't there, for reducing the incidence of post-operative pancreatitis. You had any experience of that?
We're testing it, so I'm very curious, to
really.
There is a rationale.
I just let it slip. Sorry.
No. I mean, it's not a secret. I mean, it has a rationale. And it also might explain why some preliminary data, again, from some Finnish group and also in the US, are showing the potential benefit of, hydrocortisone while in the operating room or right afterwards. So rather than being a protective factor for fistula, probably has a role in decreasing the inflammation around the pancreas in these very early phases. But I mean, still, this could be a little bit, too much of speculation, because I'm really missing, some reliable data.
And this is for the Whipple's patients, presumably you're trying this.
Yeah, but I mean, it's even more intriguing for distals. I mean, can you realize? I mean, for distals, we know way less about the pathophysiological, that it's, behind the fistula formation. We strive, to deal with the stump the best way possible. We are so sick of all these studies comparing stapler versus putting some patches and falciform and whatever. I think we're kind of missing what is the rationale underneath the formation of a fistula after a distal, which probably, as Keith pointed out, is more related to the contamination of a fluid collection, which tend to occur in 100% of cases after distal pancreatectomy. So only, you have to discriminate whether this fluid collection is relevant or not, because it's pretty, well known that you will always see a collection, after a distal, but this is also the way the pancreas, uses to heal itself, after a distal pancreatectomy. So we're way far, I would say, behind in understanding the pathophysiology of this fistula, and probably pancreatitis, has a role in this formation, because you don't have an anastomosis, which of course, increases the complexity of understanding such a phenomenon.
So maybe we should add just thinking about Keith and Ripley, maybe we should add steroid use to your paranoia data set for a period, you know, after Giovanni's data is released.
Yeah,
I was going to ask you, Giovanni, you know, there are a lot of fantastic papers from Verona. There was one study where I think there was a threshold of a drain fluid amylase of less than 5,000 was your threshold for removing the drain. But 5,000 to me always seemed quite high.
You're actually mentioning, you know, one of our, you know, milestone paper. It has now, I think, more than 15 years. It was, you know, our first trial. I wasn't even here at that time. So we are now questioning the reliability of such a threshold, because again, when you assess the risk and you define high risk cases, then you need to define new threshold. So we again broke this dogma, and we are now changing even our thresholds depending on the risk assessed in the operating room, depending on the use of mitigation strategy, like for example a stent. I mean, it's kind of obvious that if you use an external stent and most of the juice is drained out, I mean, how could this threshold, you know, work, you know, in both conditions? I mean, of course, you need to readjust such threshold if you use these tools. So I think it's the great, you know, message here is to, again, you know, refine your threshold and question what you use